In this last video, we'll be focusing on the second question of the chapter, which is which type of psychotherapy works best? So in the previous video, we established psychotherapy works overall, but there's a remaining question of which type is better than others. And so we can think about this in different ways. There is certainly competition between various overall orientations and approaches. And this is kind of at the fundamental theoretical level. There can be some very big differences that we'll get into when we talk about these orientations to psychotherapy. So the four main orientations that we'll go over for the remainder of the class, actually, so the last 3 weeks will be spent on these four orientations. We have psychodynamic therapy, humanistic therapy, behavioral therapy, and cognitive therapy. We can also have competition among what we call brand name manuals. So these are therapeutic methods that have been researched together and kind of put together in manuals. And then they are kind of known by their name, even if they share common elements with each other. So for example, these are some of the brand name PTSD treatments. So we have prolonged exposure, cognitive processing therapy, eye movement desensitization and reprocessing therapy, also known as EMDR, and acceptance and commitment therapy, or ACT, for PTSD. And so all four of these methods are going to share some things in common. They all include reviewing memories with a therapist and getting kind of used to that process of reviewing a traumatic memory. But they're going to have some minor differences in how they approach that. And those differences can kind of bring up this competition where the question can be, which one should a therapist use? So in this example, all four of these approaches have research evidence for them, but there might be different levels of evidence depending on who you're working with, depending on how long the treatment is, depending on the preferences of the therapist and the client. And so an important thing to know about psychotherapy is what was historically called the dodo bird verdict. And so this comes from Alice in Wonderland, the book. And in the book, there is a scene where a bunch of characters get wet because it's raining. And in order to dry off, the dodo bird says, we're going to have a competition. So everyone is going to run around the lake until you're dry. And in this competition, nobody measured how far each person had run, nor how long. And so then afterwards, they asked the dodo bird who won. And he thought about it and he said, everybody has won and all must have prizes. And so this story has been invoked in terms of answering this question of which psychotherapy is best. Some people argue that, in a way it's saying everybody has one and everyone must have prizes. So in that case of the four PTSD treatments, these are all well-respected treatments that, a lot of therapists are using, all four of them. And so it's hard to say who really wins that question. And this is tied to the finding that across studies, so someone did a meta-analysis and found that different forms of psychotherapy have actually been found to be roughly equal in their efficacy. And so I want you to think about why this might be. So why would therapies that have different manuals, different methods, why would they all kind of be equal in how well they work? And so the answer is what we call common factors. So common factors refer to the common things across the treatments. So like I said, if we're looking specifically at those treatments for PTSD, they're all going to incorporate sessions that involve the client, revisiting their traumatic memories with the therapist to process it in some way. And so you could just say that that is a common factor for PTSD treatment. However, if we look even broader at those orientations, so psychodynamic, humanistic, behavioral, and cognitive, those are going to differ quite a bit. So the four treatments I showed you for PTSD all fall within the cognitive behavioral tradition. But if we take a step even wider, we need to find common factors that exist across theoretical orientations. And the number one common factor that people point to is the therapeutic relationship or alliance. And so research shows us that having a strong relationship between the therapist and the client contributes to better psychotherapy outcomes. And some people even argue that this is the most crucial single aspect of therapy, that it's the best predictor of having positive outcomes, that it accounts for variability across different client and therapist combinations, and that it really helps to facilitate the positive change. And this is best characterized as having a reciprocal relationship between the client and the therapist. And people have tried to kind of break this down. So people have done research studies to look at what is this therapeutic relationship. And they've identified some specific factors. So the alliance, or the sense of working together, the sense of collaboration, goal consensus, or having the same goal that they're working on. Cohesion, which is a term that's often used in group therapy that refers to sort of like an alliance, except for like everybody being on the same page. Having empathy, positive regard and affirmation, and providing feedback. So these are all considered to be kind of these important ingredients of a strong therapeutic relationship. We can also look at other common factors across all types of psychotherapy. So for one, we have hope or positive expectations. So just the very fact that somebody is showing up for a therapy session means that there is a part of them that believes they can change. And so even the act of going to therapy, even if it's like just talking and not doing anything active in the therapy, can produce positive outcomes because it shows that the person has hope or positive expectations for change. We can also look at attention, or what is called the Hawthorne effect. So the Hawthorne effect, it refers to people change their behavior when they know they are being observed or watched. So people first recognized this in research studies when they realized that participants would kind of modify how they were acting when there was somebody taking notes on what they were doing. And this is the same in therapy. So just by having someone kind of on your team, like watching you, might make you kind of start to change your behavior for the better, even if the therapist isn't doing anything active to create that behavior change. We also have the reinforcement of novel behaviors. So a therapist is likely going to give you positive feedback when you come back and you report that you've changed or you're doing something differently. And so this reinforcement of novelty or of a new behavior is going to increase the likelihood that that behavior keeps going. We also have desensitization to threatening stimuli. And so this one's particularly relevant for that PTSD example. So what this means is the simple act of talking about your emotions, your memories, your feelings, your thoughts, makes it easier to talk about them more. So it kind of desensitizes you to the threat. So somebody going in and talking about a traumatic memory, regardless of what the processing of that looks like, is going to desensitize them to that memory and likely help produce positive results. We also have just the very fact of confronting a problem. So not just going into therapy is a good sign, but also just the creation of a goal. It's the intention around confronting a problem. And then we have skill training, which is often a component across theoretical orientations. So talking about kind of the specific logistical behavior changes, learning new things at a broad level can produce change. So these are all common factors. So what this means is these are not theorized usually to be the active ingredient in a type of psychotherapy. These are just these kind of almost secondary benefits to going to therapy that now, because of the dodo bird verdict, people are saying, well, maybe this is just what the bread and butter of therapy is. Maybe this is actually what we need. And so people have kind of organized this into what is called the three-stage model of common factors. And this refers to, it kind of organizes these other common factors that we discussed, and it refers to this process of supporting a client, teaching them new skills, and then putting those new skills into action as kind of this broad level recipe for what therapy is, regardless of what the specific support factors are, learning factors, and action factors. However, there are a lot of clinical psychologists who disagree with the dodo bird verdict. So the other side of the debate is that even though research has shown that different forms of psychotherapy have similar outcomes, this is as a whole across all therapists and clients, that does not mean that specific therapies aren't more effective for treating specific disorders. And so Diane Chambliss is kind of one of the leaders of this side of the debate. And so she really advocates for prioritizing the active ingredients of psychotherapy over the common factors. So she says that we actually do need the things, we need to understand the mechanisms of change. We need to understand why therapy is working. And it really is these more active ingredients that lead to positive outcomes. And so Diane Chambliss actually is the one who set up the criteria used on the APA Division 12's website. And you will use this both in this week's La Lima response, but also for your final project in selecting a psychotherapy. And so Diane Chambliss's opinion about active ingredients is much more common among academic clinical psychologists. So this idea that there are types of therapy that are better than others, and that it's important to really understand the mechanisms of how therapy works. And this idea of specific treatments for specific disorders makes a lot of sense. I think just at a broad level, you can understand how somebody who's going to therapy for marital counseling versus an anxiety disorder versus schizophrenia, they're going to need very different types of therapy, different levels of support. And so the active ingredients of what they're working on is going to look differently, even if the common factors of having a therapeutic alliance are the same. And so Diane Chambliss and this side of things, they're by no means are they saying that common factors are not important. They are just saying that they are not sufficient. So we need common factors, but we cannot ignore the active ingredients as well. And so while some people have argued that having this more prescriptive approach to therapy, so specific treatments for specific disorders, some people have argued that that should actually be replaced by an approach that emphasizes the common factors. But others have argued that client preference is actually the key to therapy success. So not just thinking about how well was this particular therapeutic strategy designed to treat these symptoms, but how well is the client going to engage with this intervention? And other research suggests that the therapist preference is also an important factor. And so again, overall, it's just most clinical psychologists kind of know to consider both specific and common factors when giving psychotherapy. So then we can just talk about what kinds of psychotherapy are clinical psychologists practicing. And this is a useful table to see since 1960 up until 2010, the types of theoretical orientations that clinical psychologists endorsed. And so you can see there's been a lot of change over time where, back in 1960, it was predominantly eclectic or psychodynamic. And now jumping ahead to 2010, which is the most recent available, cognitive is the most popular. And it's interesting. This is something we'll talk about later in the class when we talk about these specific approaches. I just want you to take a look now, though, and see how uncommon humanistic therapy is in terms of being endorsed. And I'm bringing this up now because it heavily relates to the common factors idea. So nowadays, a lot of people look at what humanistic therapy is, and they say, oh, those are just the common factors. It has to do with empathy, with good listening, letting the client lead the session. And so my guess, when I look at this table, is that a lot of the 31% of people who endorse cognitive therapy they are using a lot of humanistic techniques, but they are predominantly identifying as a cognitive therapist, similarly with the other orientations. And so people don't have to subscribe to one particular orientation. It's pretty common to blend orientations and to get training in multiple areas. And so we can talk about this in a few different ways. So when we say somebody takes an eclectic approach, it means that they simply, when they have a case, they select the best treatment based on the data. And then they practice the technique as they have been prescribed in the research. And so this would be, you might use a more behaviorally oriented strategy with one client, a more cognitively oriented strategy with another client, a psychodynamic approach with a third client. But each time you're kind of doing it by the book. You're following what is recommended. This differs from a more integrative approach, which is where the therapist is sort of blending techniques to create kind of a new form of therapy. This has its pros and cons. So unfortunately, when it's up to an individual therapist to blend techniques, they may be significantly changing it in ways that where it's no longer effective, or it's hard to say what is effective about it. However, if we recognize that common factors are a really important contributor to therapy outcomes, then blending techniques might be important for supporting the therapeutic alliance and kind of the individual approach to treating each client. And then we can also talk about having an assimilative approach in which somebody has a very firm grounding in one system. So they may be like, I am mostly a behavioral therapist, or I'm mostly a cognitive therapist, but they are willing to kind of incorporate other practices and views from other systems. And I think a lot of people fall into this category. So depending on where people go to school, their training tends to lean towards a particular orientation or maybe a couple orientations, and then they might borrow from other orientations. The other factor it's important to consider in terms of which types of therapy someone is practicing is where the client is at. So clients enter therapy at a lot of different points, regardless of what type of therapy it is. And so some people are ready to change, others are not. But there's a lot of support for what we call the stages of change model. And so this is the model. So starting with the pre-contemplation stage, this is when people have no intention to change. They just are how they are, and they haven't even thought about change. They are probably, they may or may not be in denial about their problems or just unaware that the problems exist. Then we have the contemplation stage, which is when the client is aware that there's a problem, but they're not ready to change it yet. And a lot of times we're not going to see clients who are like electively going to therapy who are in these first two stages, unless you work in a setting where people are forced to go to therapy. So it might be court-ordered therapy, it might be an inpatient unit, it might be at a school setting. You might come across clients who are in these stages. Most clients who are choosing to go to therapy are at least in the preparation stage. And this is when they're planning to make a change. So maybe they don't know how to make the change, but they want to change. We then have the action stage, which is when they're in the process of making a change. And then the maintenance stage. So they are attempting to prevent relapse from having already gone through a change. And so you might have clients that approach therapy when they're already in the maintenance stage and they are just wanting to prevent relapse or kind of keep going in that positive direction. And so it's really helpful to think about which types of therapies are going to work differently for people based on what stage of change they're in. And so over the next few weeks, we're going to discuss more specific, both psychotherapy theoretical orientations, as well as some specific strategies that therapists use. And so the things that we've discussed in this chapter, in chapter 11, are going to come up over and over again. So thinking about what are the active ingredients of a therapy versus a common factor, and which types, like how do you choose which types of therapy to give which type of client?